All right, let's jump right in. Picture this, you're the attending physician on the wards, and a patient has just rolled in with a neurologic symptom following some kind of trauma or exposure. Your goal today isn't just rote memorization, it's about mastering that rapid-fire, test-day decision logic for the Step 2 CK exam. In this explainer, we're going to build a mental clinical algorithm to triage these exact scenarios on the spot. We've got 6 branches on our triage tree today. 1. Normal aging versus acute deficits. 2. Tick paralysis exposures. 3. High-risk adult head trauma. 4. Pediatric mild traumatic brain injury. 5. Concussion and CSF rhinorrhea. And 6. Cerebral venous sinus thrombosis. Starting with Section 1, normal aging versus acute deficits, it's absolutely crucial to distinguish a benign baseline change from a glaring pathological red flag. So keep in mind a slow decline in things like executive function, attention span, and problem solving after age 70, that can actually be completely normal. Normal aging also frequently comes with a loss of distal vibratory sensation, decreased ankle deep tendon reflexes, a sluggish pupillary light response, presbyopia, decreased hearing, and even a broad-based gait with a shortened stride. Do not let the test makers trick you into thinking these are acute strokes or dementia. The true red flags you want to look for are a patient who cannot remember specific instances of forgetfulness, marked functional impairment, rapid functional decline, genuinely unsafe gait changes, or any focal neurologic deficits. Oh, and a quick aside, contrast that benign distal vibratory loss with a stocking glove sensory loss. If you see a stocking glove pattern, that points directly to a pathologic distal symmetric polyneuropathy. Moving to Section 2, tick paralysis exposures. Okay, the ultimate test day discriminator for a patient presenting with ascending weakness after, say, a hiking trip, it all comes down to the speed of onset and the spinal fluid. Tick paralysis hits with a rapidly progressive ascending weakness, totally absent fever, absent sensory symptoms, diminished reflexes, and this is the kicker, a perfectly normal CSF exam. Now, Guillain-Barré syndrome can look super similar, but it's typically less rapid, it's more symmetric, and it notoriously features CSF abnormalities, along with autonomic dysfunction. So if you see that rapid onset with normal CSF, your next best step in management is to do a meticulous search for that tick and get it removed immediately. Section 3, high-risk adult head trauma. Let's get into the trauma bay. You absolutely have to recognize these visual buzzwords. These are high-risk signs of a basilar skull fracture. Raccoon eyes, meaning bilateral periorbital ecchymosis, suggests an anterior basilar skull fracture. Battle sign, which is mastoid ecchymosis, points to a posterior fracture. Also, keep your eyes peeled for hemotympanum, CSF rhinorrhea, and CSF otorrhea. Spotting literally any of these automatically escalates your trauma pathway. So, what exactly triggers a head CT? First off, you're ordering a non-contrast head CT. Remember, no contrast, because new blood appears white on a CT and contrast also appears white, meaning they'll just obscure each other. The high-yield triggers for that scan are age 65 or older, coagulopathy, drug or alcohol intoxication, dangerous mechanisms like falling from a height or being struck by a car, retrograde amnesia of 30 minutes or more, vomiting 2 or more times, a seizure, a severe headache, a Glasgow Coma Scale of 14 or less, a suspected depressed skull fracture, altered mental status, loss of consciousness, any focal neurologic deficit, or any of those basilar skull fracture signs we just talked about. Any of those, get the scan. Section 4, pediatric mild traumatic brain injury. Let's shift to the kids. Let's look at the under 2 age group first. Mild TBI generally might just be a brief loss of consciousness, a headache, or a little vomiting. But for these infants and toddlers, you are specifically hunting for altered mental status, like severe fussiness, loss of consciousness, or a severe mechanism of injury. The absolute highest yield test day triggers to burn into your memory here are a non-frontal scalp hematoma or a palpable skull fracture. If you see those, it aggressively drives your decision to image. Now for older kids ages 2 to 18, the triggers shift just a bit. You're still watching for altered mental status, loss of consciousness, and a severe mechanism, but vomiting, severe headache, and basilar skull fracture signs become the primary red flags. Based on these risk features, your management is going to be one of 2 things. Either a head CT scan without contrast, or if they fall into a lower risk category without those severe symptoms, you just do 4 to 6 hours of observation. Section 5, concussion and CSF rhinorrhea.
CSF rhinorrhea is tricky because it can appear immediately after accidental or surgical trauma, or it can show up unexpectedly days to months later as acute tissue edema resolves. The classic clinical vignette you'll see is a patient complaining of a unilateral watery runny nose with a distinct salty or metallic taste. That's a huge red flag because it carries a high risk of meningitis. For the evaluation, you need to test the fluid for CSF-specific proteins, namely beta-2 transferrin or beta-trace protein. You might also need imaging with intrathecal contrast or maybe an endoscopy. Management is strict: bed rest, head of bed elevation, totally avoiding straining, and potentially placing a lumbar drain or doing a surgical repair if it just won't stop.
Okay, let's talk concussions. A concussion is a transient neurologic disturbance following mild TBI with absolutely zero structural intracranial injury. Symptoms are things like dizziness, disorientation, amnesia, headache, and light or noise sensitivity. The protocol is a super strict timeline: immediate removal from same-day play, followed by a thorough neurologic evaluation, a minimum of 24 hours of total rest, and then a gradual stepwise return to physical and neurocognitive activity, assuming symptoms don't get worse. But be careful here. Atypical signs like focal neurologic deficits, depressed or worsening mental status, or skull fracture signs mean you immediately abandon this protocol and get a CT. And just to completely contrast this with severe TBI management, a severe TBI patient might actually develop paroxysmal sympathetic hyperactivity. Those are sudden, massive autonomic episodes of tachycardia, hypertension, and tachypnea. That's a totally different ballpark. But what if those concussion symptoms, the headache, the dizziness, sleep disturbances, mood changes, and cognitive impairment, what if they last for more than 4 weeks after the mild TBI? Well, then we've entered post-concussion syndrome. The risk for this goes way up with multiple prior concussions, or if the patient just didn't adhere to the return-to-play protocol we just outlined. Remember, the structural imaging will still be entirely negative. Management here relies on symptomatic care and activity as tolerated.
Section 6. Cerebral venous sinus thrombosis.
For cerebral venous sinus thrombosis, or CVST, you really need to connect a hypercoagulable clinical vignette directly to the diagnosis. If you've got a patient with thrombophilia, malignancy, severe facial infection, or someone in the postpartum state, or even just taking oral contraceptive pills, and they present with a severe headache, vomiting, signs of elevated intracranial pressure like papilledema, focal neurologic symptoms, seizures, or encephalopathy, you need to suspect CVST. A quick note on the differential here. If it's a severe facial infection presenting specifically with ophthalmoplegia, that might point to cavernous sinus syndrome, which is a related but distinct vascular emergency. To definitively diagnose CVST, an MRI of the brain with MR venography is going to give you the highest sensitivity. However, a CT scan with CT venography is often what's used when rapid availability matters in the emergency department, and grabbing a D-dimer can further support the diagnosis.
And here's your final super high-yield clinical takeaway. The acute treatment for cerebral venous sinus thrombosis is anticoagulation with unfractionated heparin or low molecular weight heparin. This holds true even if the imaging shows a small area of secondary intracranial hemorrhage caused by the venous backup. Seriously, you still give the heparin. The primary issue is the clot in the sinus, and you absolutely must treat it. Mastering these triage pathways isn't just about selecting the right multiple-choice answer. It's about developing those lightning-fast clinical reflexes to separate a benign presentation from a devastating emergency. So the next time a patient walks into the ER with a headache after a fall, ask yourself, are you looking at a simple bump on the head or the calm before a neurological storm?